He had his local training at the Institute of Cardiology, Colombo, and he undertook his overseas training in cardiology at Papworth Hospital, UK. He is currently serving as a honorary consultant cardiologist at Teaching Hospital, Batticaloa, and a senior lecturer in medicine at the Faculty of Healthcare Sciences, Eastern University of Sri Lanka. So over to you, Dr. Rajeevan.
Thank you, sir. Thank you for that kind introduction. So let's go directly to our topic. So the topic that was given to me is to talk about fluid and electrolyte balance. So this is a very common topic. I mean, and in a way, very basic topic, because you have been looking at fluid and electrolyte balance, I'm sure, from your first or second years as medical students, or even before that. So this is something that we have been always looking into. But still, this fluid and electrolyte balance is a very important area that is unfortunately overlooked many times when we look at our critical care, in our critical care patients. So, sorry, yeah. Okay. So let's have a look at where we came from. So humans and all animals on Earth evolved from unicellular organisms. So this evolution started somewhere around 3.5 billion years ago and has been going on. Now, these unicellular organisms, they've initially developed or were created or were formed in the ancient sea. Now, this sea, which surrounded these cells, was actually the first extracellular fluid environment. So all living things still retain this ionic makeup of that ancient ocean. So if you look at our electrolytes that we find in our body, you can see that sodium is the most commonest cation. In the sea, salt is the commonest, sodium is the commonest cation. So this blood plasma itself is regarded at the moment as a relic of the ancient sea. So over these billions of years, the body, from its initiation as a unicellular organism or unicellular microbe till it has reached this multicellular state, we still retain this fluid, this composition around us, around each of our cells. So if we look at the cardiovascular system, the whole purpose of this cardiovascular system, where we have the heart, the arteries, the veins, the entire circulatory system, the whole purpose is geared to provide this extracellular fluid to the individual cells. Then our cells work together as tissues and as organs to keep us living as human beings. So the whole purpose is to provide this fluid environment, which was similar to the ancient times. Now, this fluid composition of water and electrolytes is very important. So you can see that for 3.5 billion years, these cells have been maintaining this type of an environment. So that indicates how important it is to have this environment around the cells. When patients are in the critical state or in the ICU or CCU or wherever, this environment gets upset. And it's our aim and our purpose to somehow ensure that there is a suitable environment, this suitable fluid, surrounding fluid and electrolyte environment for the individual cells. Because the cells need this environment to survive. If they had been capable of living in various environments, then we would have evolved in different ways. But all cells, all over, in all organisms, they still maintain this particular composition, this particular level of electrolytes in order to work as biological entities. So this highlights its importance. So Many studies have repeatedly shown that fluid and electrolyte imbalances are associated with increased mortality and morbidity in critically ill patients. Now, many things put these patients at risk. It's the disease condition itself, say patients who come with heart failure. So for them, the cardiovascular system is now not functioning properly. So the cells, they are unable to get the proper fluid environment that they need. Then we might be giving we might give fluids extravenously from outside. The patients will not be eating. They may have problems with passing urine. The electrolytes and metabolites that are not needed by the cells should be removed. Those are not happening. So various things at various levels put the patients, critically ill patients, at risk of this electrolyte and fluid imbalances. So in order to maintain these fluid and electrolyte imbalances, what are we as professionals, as doctors looking after these patients, what are we going to do? And how are we going to assess the need and replace or correct whatever imbalances that occur in these patients? So for convenience sake, I'm going to separate my topic into two. One is the fluid management or fluid environment and the electrolyte environment. That's not to say that they are both separate. They are both interrelated. They are both connected together. But for our ease, it's in a way easy to sort of categorize it in this way. Right. So I'm sure you all are all well aware of this picture. We have been looking at it from our first years of physiology. So this is a capillary has been shown. We have the arterial end and we have the venous end. We have tissue fluid forms. So at the arterial end, we have the hydrostatic pressure, which pushes the fluid out through filtration into the extracellular environment. And thereafter, at the venous end, when we have a drop in this hydrostatic pressure, and also as the fluid leaks out, there is an increase in the osmotic pressure within the blood vessels, and this pulls the fluid back into the capillaries. This ensures that a circle of fluid is continuously moving inside this extracellular compartment. This movement of fluid gives the necessary oxygen and nutrients to cells and takes away the wastes and the other products and the unnecessary products from the tissues. So whenever these factors are affected at the arterial end, venous end, or at the oncotic pressure, then there is going to be a problem of the cells receiving the necessary fluid environment. So the main factors are decreased hydrostatic pressure at the arterial end. So this can happen due to many reasons. Number one is due to pump failure. So when the heart does not pump properly, if it cannot produce adequate pressure, then there is going to be a decrease of hydrostatic pressure. So we'll have a look at what are the other causes. Then, of course, we have increased hydrostatic pressure at the venous end. Similarly, again, when you take cardiac failure, the venous return is impaired. This will cause increased hydrostatic pressure at the venous end, and this will lead to excessive fluid reaching these extracellular compartments, which manifests in the lungs as pulmonary edema and in the tissues as peripheral edema, or within certain organs like the liver congestion, and so on. Decreased blood colloidal osmotic pressure can be seen in conditions such as hypoalbuminemia, which does not allow or does not produce enough osmotic pressure for the cells to pull the fluid back into the capillaries, and this results in edema, tissue edema development. So these are things that we have to consider whenever we are talking about maintaining this fluid environment. So inadequate tissue perfusion. So when we talk about the fluid environment, we are talking about these capillaries. So that brings us to the term of tissue perfusion. The tissues should receive an adequate volume of blood at an adequate pressure. That will then only this tissue fluid can form. If this does not happen, then it's going to impair all vital organs and then lead to multi-organ failure and so on. Early recognition is very, very important to provide circulatory support, because as time goes by, the chances of survival dramatically drop. So you can see in this chart shows survival, this chart that I've shown here, this shows survival against time. So as we delay, the longer we delay, then the longer we delay resuscitation, the more organ damage is going to happen. So time is of essence. Right. So if you look at the cardiovascular status affecting this tissue fluid formation, as I said, number one is pump failure, where the heart does not produce an adequate arterial pressure. There are many reasons for this pump failure. So whenever we are faced with a critically ill patient who is having inadequate tissue perfusion, we'll see how we can assess this tissue perfusion. Then the first thought that comes into our mind is this pump failure? So when you talk about pump failure, it may be failure of the left ventricle, it may be failure of the right ventricle, it may be other conditions like cardiac tamponade. Cardiac tamponade, where you have a pericardial effusion around the heart, which is compressing the chambers and not allowing the heart to produce an adequate cardiac output. Or it may be due to some tight valvular lesion, like aortic stenosis, tight aortic stenosis, which is not allowing the ventricles to pump the blood in an adequate volume. Then there may be inadequate intravascular volume, hypovolemia. Again, many reasons, maybe GI losses, maybe blood losses, maybe due to dehydration. So wherever there is inadequate fluid within the intravascular compartment, again, there is going to be impaired tissue fluid formation. Another thing to consider, if the heart is okay, pumping well, okay, there is adequate intravascular volume, then the next thing that we should think about is this loss of arterial vascular tone. This is again very important to maintain an adequate arterial pressure. Now, this loss of arterial tone is typically seen in conditions such as sepsis. So in septicemia or septic shock, we see there is loss of this arterial vascular tone. So the patients have a good volume pulse, heart is hypercontractile, but the tissues are hypoxic because they are not getting adequate tissue perfusion. Another lesser or rarer thing that we can see sometimes is acute obstruction of the arterial tree, typically something like pulmonary embolism. Right. So this management of pump failure. So yes, number one is treat the cause. We have to somehow ensure adequate cardiac output. So I'm not going to go into the individual management of each of these conditions. That is for other topics. But I want you to appreciate that whenever you're talking about fluid management, always we have to think about this pump failure and the causes, underlying causes for pump failure and how it can be treated. Sometimes we may need to give inotropes for these patients to improve the cardiac contractility or to improve the arterial tone, to increase the hydrostatic pressure at the arterial end of the capillaries. Sometimes we might actually use arterial vasodilators. This can be seen in conditions where you like in a hypertensive emergency, where you have severe hypertension. So the arteries are so vasoconstricted that they are not allowing the heart to produce an adequate cardiac output. So therefore, due to that, the organs are going to get damaged. There is not enough blood there is not enough cardiac output being produced to reach the tissues, and therefore we might have to use arterial vasodilators when we are talking about managing this pump failure at certain times. Whatever it is, we want to maintain an adequate blood pressure. So the adequate blood pressure is a mean arterial pressure of more than 60 millimeter Hg. So newer studies have shown, so this is the traditional minimum mean arterial pressure. So if we have a mean arterial pressure of 60 millimeter G only, we will have an adequate hydrostatic pressure at the capillary ends to produce this tissue fluid. But studies have shown that actually having a higher MAP is better and has a better survival uh, uh, than just going at the bare minimum. So if you see now, there are recommendations where, or in the ICU setup, we try to maintain a higher MAP for many of our critical patients. But anyhow, this is the minimum. We cannot drop anything less than this. Anything less than this, the patient is definitely going to go into multi-organ failure. Right. So then when we talk about management of the intravascular volume, number one thing is how we have to assess to the volume status of the patient and the fluid responsiveness. So two things, volume status and fluid responsiveness. Is the patient hypovolemic or hypervolemic, euvolemic? Is this problem that we are facing, this inadequate tissue perfusion or inadequate blood, which will be reflected by the inadequate blood pressure, is it fluid responsive or not? So there are various ways of looking at this fluid responsiveness, from raising the leg test, invasive monitoring, non-invasive monitoring. There are various ways of looking at this fluid responsiveness. Two things we have to think about: is there volume depletion or is there volume overload? If there is volume depletion, then that is going to lead to hypotension, shock, organ perfusion, and the rest. Volume overload also will lead to impaired oxygenation because of pulmonary edema. Peripheral edema will cause inadequate tissue perfusion and impaired tissue fluid formation, hypertension, and organ congestions. So therefore, we always have to keep this in our mind. We do not want to have volume depletion, and we do not want fluid overload as well. As a general thing, usually this volume depletion is seen very often in patients who are nil by mouth, who are kept in the ICU setting or wherever for a long time. Those patients, we very often encounter, they have lot of volume depleted problems. Volume overload, usually when the patient presents acutely, the acute patients, they come volume overloaded for various reasons. So just some things to keep in mind. Right. So when it comes to this fluid management or fluid overload and fluid thing, we should start resuscitation by looking at some triggers. So I have given this chart is a very detailed slide. So what are our triggers to start IV fluids? So a MAP, if a mean arterial pressure less than 65, it's an indication. So rising lactate level of more than 3. So these are the common things that we look at. Then our next phase, so that is our initial resuscitation phase. Then we want to go to an optimization phase where we want to maintain fluids, where we are looking, is the patient getting fluid overloaded or are we giving enough fluids? And then we are going for this stabilization. So that is where we are going to start removing the fluids and slowly tailing off. Then we have the evacuation phase where we want to stop fluids. Now the patient is fluid overloaded, and therefore we need to do certain maneuvers to remove the excess fluid. So this is a slide which you all can go through in detail. There are a lot of minor details there which will be helpful. Right. Then when we come to this loss of arterial vascular tone, usually seen in critically ill patients. As I said, patients with sepsis is the typical example. However, any patient who is critically ill for a long time, even if the patient comes with cardiogenic shock, during the initial phase, what we find, we will see there is increased vasoconstriction, increased sympathetic activity. The body is trying its best to maintain adequate blood pressure. But that does not last for long. Within 1 or 2 days, then this reverses to a vasodilated state, and then the patient is going to start deteriorating. Now, management is going to be to correct the cause. Like if it's sepsis, we want to correct the sepsis. Acidosis is an important cause for this poor arterial vascular tone. When the patient is acidotic, then endogenous vasoconstrictors do not work. Even our inotropes that we give are not going to work properly. They are going to be suboptimal. So correction of acidosis is very, very important. Then, of course, yes, we might need to give exogenous vasoconstrictors like inotropes, noradrenaline, vasopressin, depending on the cause, depending on the etiology. We might want to give some type of inotropic support to cause this or induce vasoconstriction to bring up the blood pressure. So see, everything is aiming ultimately to increase the hydrostatic pressure at the capillary end. Yes, this is of course straightforward. Basically, if there's an obstruction anywhere to the arterial tree, then it's going to obviously block the blood from flowing, and it's going to cause drop in hydrostatic pressure at the capillary end. Pulmonary embolism is the typical example. Right. So now how are we going to assess this perfusion? So now we have seen the causes, we have seen the ways of improving this tissue perfusion. So these are the things that we are always going to look at. Or clinically, how is the patient? The skin color, if the patients are pale, they look clammy, then by looking at the patient itself, you know this patient is, the tissue perfusion is low. Patients with low tissue perfusion, their peripheral temperature will drop. They might become hypothermic. Skin turgor. By the time skin turgor is lost, that means a large volume of fluid has to be replaced. Capillary refill time can be seen. The pulse volume is another good indicator of tissue perfusion in a patient with a good pulse. I mean, there may be different reasons, but serially by assessing the pulse volume in the same patient, then we can assess or see how the patient is responding to our resuscitation. Yes, and sweating. If the skin is dry, then that indicates that there is inadequate tissue perfusion. Another important way of monitoring this tissue perfusion is to look at the urine output. Assuming that the patient's renal functions or renal kidney is able to produce urine normally, a urine output of less than 0.5 ml per kilogram per hour should be taken as inadequate perfusion to the kidney. So this is a surrogate marker of the cardiac output. Urine output is considered as a surrogate marker of cardiac output. If the patient is producing a good urine output without the help of diuretics, then we can assume that the patient is having an adequate cardiac output because the kidneys are perfused adequately. Metabolic acidosis and rising lactate. This is another good indicator to look at tissue perfusion. If the lactate levels are rising, then that tells you that anaerobic metabolism is happening at the tissue level, which means that there is inadequate oxygen and nutrients reaching the cells. So that means automatically we are coming back to what we talked, that is inadequate fluid reaching the cells or inadequate pressure. So the capillary system is not working properly. So serial measurements of this blood gas and looking at rising lactate. Similarly, if our resuscitation is successful, we will expect to see that this lactate level coming down. Then, of course, improvement or deterioration of organ markers, such as liver functions, renal functions. If they improve or deteriorate, again, they will indicate to us that this organ perfusion is improving or deteriorating. But these are very late markers. So by the time that if the tissue markers are elevating, liver functions are elevating, renal functions are elevating, then that tells you that organ damage has happened. We do not want that to happen. We have to catch the patient or correct the abnormality before these abnormalities occur. Right. So that is for tissues, for the fluid. Then let's have a look at the importance of this electrolyte balance. Now, there are a number of other electrolytes. You can see I put here 4 electrolytes: sodium, potassium, calcium, and magnesium. There are other things like chloride, phosphate. There are various other electrolytes also that are found in our system. But these are the 4 main electrolytes that if we can maintain a balance of these 4 electrolytes, then 99% of our job is done. Now, maintaining electrolyte balance is a bit tricky because we have to maintain electrolyte balance within the cells and within the extracellular compartment. But we have no way of looking at the electrolyte balance within the cells or in the extracellular compartment. What we have is the blood or serum electrolytes that can be done. Now, the serum electrolytes and the extracellular electrolyte balance are going to be correct, going to be equal in most tissues apart from the brain. So apart from the brain, in all the tissues, the electrolytes that we measure in the serum is going to be the same in the that is found in the extracellular fluids. So our aim is somehow to maintain this balance. So the importance of maintaining this extracellular fluid. Now, the intracellular electrolyte balance, we cannot look at it, we cannot measure it. But as long as we are able to provide this environment for the cell is an amazing thing. It will be able to use the energy that it has in the form of ATP to somehow build up or maintain its internal electrolyte balance. What we have to do, our role is to give this environment, the surrounding environment for the cell. The cell will somehow maintain it, will correct the internal electrolyte balance. So this balance is very important for all of the bodily functions. So again, when we are coming back to our ancient primordial sea, as we see in the sea even currently, sodium is the most commonest electrolyte, and it is the most commonest electrolyte abnormality that we see. This is regardless of whether the patient is a cardiac patient or a critical patient for any other reason. So very often we find in the CCU, we are managing not only, even though we say we are managing cardiac patients, we are managing many other abnormalities as well. So wherever we come, this sodium is the most commonest electrolyte abnormality that we see, which can be hypo or hyper. Now, this sodium balance or sodium abnormality that we see is generally due to changes in the total body water. Water and sodium, the link between the sodium and water is inseparable. Whenever we talk about sodium balance, we have to talk about water balance, total water balance, and vice versa. Now, normally the body, it maintains the sodium balance by controlling the water intake and water excretion. So there are many mechanisms in the body to do this. Now, the extracellular fluid, if you look at the extracellular fluid or at our serum electrolytes, we will see that the sodium is usually around 141, so 135 to 145 millimoles per liter of sodium is found outside the cell. Within the cell, within the intracellular fluid, it's going to be 10 millimoles. So there's a vast gradient between the extracellular and this intracellular fluid composition of sodium. So any change, so when you take the intracellular fluid, it has to be around 10. A small change, even 9, just for even a change of 1 millimole per liter is going to cause a very significant, that's 10% change in the electrolyte compartment. Whereas here for a 10% change, you have to have a massive change of millimoles in the extracellular compartment. So the balance of maintaining an adequate or correct extracellular fluid sodium is very important to maintain a proper intracellular fluid balance. So the most commonest, one of the commonest, or really actually the commonest abnormality that we see is hyponatremia, which can be defined as a serum sodium of less than 135 millimoles per liter. Now, the symptoms of hyponatremia are very vague. Very often they are asymptomatic or having some vague symptoms, or very often actually we see this in patients who are critically ill with all other symptoms. So identifying a proper symptom that this is due to hyponatremia is rather difficult because it's the symptoms are rather vague. So therefore, it's very important or imperative that we check the serum electrolytes, that is the sodium level. If there is more severe hyponatremia, then that can lead to respiratory arrest, coma, seizures, severe symptoms. Now, this hyponatremia, we can classify it as either acute, if it is less than, okay, it should be less than 24 hours, is hyponatremia, acute hyponatremia, or chronic, when it's more than 48 hours. Now, based on the serum sodium level, also we can classify as mild, moderate, or severe. Now, the causes of this hyponatremia are large. There are a whole lot of causes to consider. So whenever we see a report of a low serum sodium, it may be pseudo hyponatremia as well. So there are causes of where the report is wrong. So once you have confirmed that it is actually a true hyponatremia, then it's important that we do the serum osmolarity to differentiate within these three groups. Is it isotonic hyponatremia? Is it a hypotonic hyponatremia or a hypertonic hyponatremia? So our management is going to be depending on these osmolarity and the causes. Then it's important that we look at the volume status. Is it hypovolemic, euvolemic, or hypervolemic in patients who have hypotonic hyponatremia? So this is how we go through the causes of hyponatremia to come to a conclusion of this is the cause. So because we have to somehow identify the cause to treat. So when we come to treatment, I'm going to concentrate only on symptomatic and severe hyponatremia. For milder forms, we can just go for fluid restriction, or we can treat with 0.9% normal saline to correct the serum sodium if needed. But when patients are symptomatic and having severe hyponatremia, then we have to go with hypertonic sodium chloride, which is 3% sodium chloride, which is infused at a rate of 1 to 2 ml per kilogram per hour. We want to slowly raise the concentration by around 1 to 2 millimoles per hour until the symptoms resolve. Now, this is only for the initial phase of management until the symptoms resolve. So maybe the patient is having seizures. The patient may be in coma. So until these symptoms resolve, we are going to slowly increase the serum sodium levels by giving this 3% sodium. Now, there is a problem with rapid correction of hyponatremia. So we'll come to that. So therefore, patients who have had hyponatremia for a longer time, we are falling under the category of chronic hyponatremia. We want to treat them at a slower rate. Once we have achieved our level, then we are going to either go for maintenance with 0.9% normal saline, or sometimes we might go for 3% hypertonic saline. However, we want to go for a correction rate of 0.5 millimoles per liter per hour it's important that we should not exceed 8 to 12 millimoles for 24 hours. Because if we do that, then we risk this osmotic demyelination. So what is osmotic demyelination syndrome? Previously known as central pontine myelinolysis. So usually a few days after this overcorrection, the patients start to develop some neurological symptoms based mainly due to abnormalities that happen around the basal ganglion region. Unfortunately, these symptoms are irreversible. There is demyelination of the CNS in certain regions, and this MRI will show a demyelinating lesion. This is called the trident sign. So we can see a sign like a trident, like having a three-pronged instrument. It's a trident. So this is called the trident sign. So in order to prevent this osmotic demyelinated syndrome, we should not correct hyponatremia too fast, because it's an irreversible condition. Irreversible damage will be done. Then we can come to hypernatremia. So hypernatremia is again defined as serum sodium of more than 145 millimoles per liter. Again, it's, as I said, water and sodium balance, usually due to deficit of water. Sodium is going to be there in the body. There is going to be some reason, for some reason, whatever, there is loss of body water, which then leads to hypernatremia. Now, usually when the patient gets thirsty, they will drink water and the body will compensate. But when patients are, say, intubated, or patients who have who are mentally who are mentally depressed, who do not who cannot drink water due to, say, having a stroke or something. So whenever this access to free water is impaired, these are the patients who we are going to see this hypernatremia occurring. And also it more commonly affects the extremes of ages. So it's seen in the pediatric population or elderly patients. Usually in adult patients, if this sodium exceeds 160 millimoles per liter, we will start seeing various manifestations of hypernatremia. So when you come to treatment of hypernatremia, again, we want to address the cause. We want to correct any hypertonicity, and we want to avoid getting cerebral edema. Treatment of hypernatremia can lead to cerebral edema. So we'll see about that as well. So whenever we see there is a volume deficit and hypernatremia, then the most simple way is to treat the patient with isotonic sodium chloride or 0.9% normal saline. Once we have replaced the volume, and if the patient is still hypernatremic, then we can go ahead with more hypotonic fluids. So hypotonic fluids, the choice of the hypotonic fluid is, there are a lot of choices. So if the patient can take orally, then free water, that's fine. If we have to give IV, then 5% dextrose is equal to free water. Then we have other lesser degrees of isotonic on half normal saline and things. So whatever it is, if it is a more hypotonic solution that we are giving, we have to infuse at a slower rate. So the choice of the fluid is going to depend on the volume status of the patient. So then if it is if it's acute hypernatremia, we definitely know the patient has developed hypernatremia within this period, then we can go at a rate of around 2 to 3 millimoles per hour. We can try to bring down the hypernatremia or the serum sodium by infusing any of our fluids. We want to measure the serum electrolytes very closely, and also we want to do any serial neurological examination. If it's chronic hypernatremia, then we should be more careful and we should correct more slowly. Yeah, because if we correct it too fast, then we risk causing cerebral edema. Okay, the next action that we see is potassium. So again, potassium is essential for all body systems. Now, 98% of the potassium in our body is located intracellularly. This potassium is very important for the membrane potential, resting membrane potential across the cells. Now, we all know about the sodium potassium ATPase pump. This sodium potassium ATPase pump is the most important intracellular organ or system within in the cells, because it's like the battery or the power station of the cells. It's by maintaining this gradient across the cell membranes, all the cellular functions that happen is able to all the functions are able to function because of this potential across the resting membrane. So this is maintained by having this potassium gradient across the membranes. Now, abnormalities can lead to very cardiac arrhythmias, are the commonest thing that we see. Muscle weakness, hypokalemia, hyperkalemia, both can lead to muscle paralysis, and respiratory failure can ensure. Again, if you look at the intracellular and extracellular fluid, it's opposite to what we see with sodium. So here we have low potassium outside and high concentration inside the cells. So if you look at the abnormalities, we can see hyperkalemia. So hyperkalemia we define as a potassium of more than 5.5. It's seen in various conditions. We can classify as mild, moderate, severe. Clinical presentation, usually, very commonly, it's asymptomatic. We find serum, the potassium is high on the reports, but it can lead to life-threatening conditions. So that's why we are very worried about this serum potassium. But patient may be asymptomatic. A few minutes later, the patient might arrest due to a ventricular rhythm. So therefore, it's very important that we correct the hyperkalemia when needed. An important thing to think about or have in mind whenever we are approaching correction of potassium is what is the blood gas status of the patient. Acidosis and alkalosis, both are going to affect the patient's potassium balance. For example, if the patient is acidotic, then it's going to lead to increased potassium in the serum. Potassium is going to leak out from the cells, and the patient is going to be hyperkalemic. So always remember, whenever we are thinking about correcting potassium, think about what is the blood gas in this patient. Right. Again, so if you see a report of an abnormal potassium, we have to think, is it pseudo hyperkalemia or true hyperkalemia? Now, true hyperkalemia is due to two reasons. One is it can be due to this cellular shift, that is the potassium within the cells are leaking out due to some reason. The other common thing that we can see, that it may be increased potassium being produced. Like if you have patients with hemolysis, from within the cells, this potassium is coming out into the cells. It's not due to a cellular shift. It is due to basically potassium. The potassium within the cells is coming out. Also, it can be due to reduced urinary excretion due to various causes. If you look at the ECG, we have ECG changes from this peak tinted T waves, very common undergraduate question. So they are till what we reach this sine wave pattern. If we see a sine wave pattern in an ECG, the patient is going to arrest within the next few minutes. We have to act immediately. So when you say act immediately, the immediate thing that we want to aim at is stabilization of the cardiac membrane. That is done by giving calcium gluconate. Now, this sine wave, when we look at the ECG monitor, it will be going like this, like this, like this, like this. As we infuse this calcium gluconate, but we usually give it at a rate of 10 ml, 10% over 10 minutes of calcium gluconate. As we infuse, we will be able to beautifully see this rhythm, this abnormal sine wave come back to normal, nice, thin, beautiful QRS pattern will develop. But after some time, around 20-30 minutes later, again, slowly this QRS will start to widen, and again it will go into this sine wave. So it's important that whenever we see a sine wave, to monitor the patient carefully and repeatedly give the calcium gluconate to keep on stabilizing the heart muscles until definitive management takes place and the potassium is removed from the serum or from the body. So if you look at the emergency management of hyperkalemia, number one, we have to do the ECG and look for ECG changes. If there are ECG changes, then administer calcium gluconate, 10 ml, 10% over 10 minutes. And then we do things to try to shift the potassium into the cells. So we can give a combination of insulin and dextrose, which works through the sodium insulin exchanger, and it can push the potassium into the cells. Beta agonists also will help to shift the potassium into the cells. Then we go for ways of removing excess potassium from the body, which may be hemodialysis or other ways of removing the potassium from the body. That is, if the patient is having excessive potassium. Now, in conditions such as diabetic ketoacidosis, there may be hyperkalemia initially. When we treat, then the patient can become hypokalemic. So those type of, I think the total body potassium is low. So there we will not have to go for any removal of potassium. If you look at hypokalemia, then here life-threatening hypokalemia is seen when you have a serum potassium of less than 2.5. Again, the symptoms of hypokalemia are very vague. Muscle cramps is the commonest thing that we see, muscle pain, muscle cramps type of picture. But it can also lead to arrhythmias and cause death. So if you look at the ECG changes, we will see that we can see two types of changes. One is we can see a U wave. The U wave is also possible. Then we can also sometimes see a depression. So here we actually think of, like in hyperkalemia, it is someone is taking the T wave and pulling it up, the pull factor. Here in hypokalemia, it will be like someone is pushing the ECG wave down just before the T wave, so it can go down and come. So these are ECG changes that we look for in hypokalemia. Again, if you look at the causes, various causes to think about: low intake, excessive loss, or transcellular shift. So whenever we are having hypokalemia, always treat the cause. Our goals of treatment are: one, we want to further stop this potassium loss. We want to replace the loss and treat the underlying cause. So stopping the loss and treating the underlying cause, we have to identify the cause and treat. Now, replenishing the potassium stores. Here, what we administer is we give potassium chloride, can be given IV. So the goal is to treat the potassium or improve this potassium levels to around 3.5 to 4.5 milligrams. We want to give it slowly, because remember, we want the potassium to go into the cells. So it's going to take time. If we give the potassium too fast, we will result in increased serum potassium outside hyperkalemia, but within the cells, we won't have adequate potassium. So we have to give this infusion slowly. So whenever we correct hypokalemia, we will administer this IV potassium chloride if can be administered through the peripheral line, it can cause irritation. So therefore, whenever we are giving, it should be well diluted and it should be at a rate of 10 millimoles per hour. Through a central line, we can give faster, around 20 millimoles per hour, well diluted. If sometimes we might want to give faster, severe hypokalemia, patient is going into muscle paralysis. So in those type of cases, we might want to give it faster, but in that case, we have to go through a central line and we should have continuous cardiac monitoring. Whenever when we talk about this hypokalemia, when we are treating it, remember magnesium. If the patient is hypomagnesiemic, then correction of hypokalemia is going to be difficult. So whenever you have a patient who you are treating, you are correcting the hypokalemia, but it's not getting corrected, always think, how is the magnesium in this patient? You might need to correct the magnesium. Otherwise, all the potassium that you are giving will get lost in the urine. Right. So calcium is the other ion that we are talking about. So most of the calcium in the body is found in the bones. Only a very small amount is found in the plasma. And of that also, a very small amount is only this active calcium. Now, when we measure the calcium, we might measure the total calcium. Total calcium depends a lot on the albumin status of the serum, because most of the calcium is bound to albumin. So that's why whenever you see the report, we get corrected calcium, that is corrected for albumin. And otherwise, we have to go for looking at this ionized calcium. So ionized calcium is the best measurement if you are looking at really critically ill patients. Now, when you talk about hypocalcemia, when you're looking at the ionized calcium level of less than 4.4 or total calcium of less than 8.4 milligram per deciliter. Again, it can be asymptomatic. There can be some neuromuscular irritability, spasms. Crozier sign can be seen in acute hypocalcemia. Another interesting thing to remember is hypotension. Severe hypocalcemia can cause hypotension. So whenever we have a patient who is not responding to inotropes, who is poorly responding to inotropes, two metabolic causes should be thought of. Maybe due to other causes as well, but two metabolic causes. Number one is the patient acidotic? If the patient is acidotic, then inotropes are not going to function properly. The other thing to consider is hypocalcemia. If the patient is severely hypocalcemic, then the inotropes that we give, because the inotropes have to work through increasing the intracellular calcium levels, that will only cause vasoconstriction or increased myocardial contraction in everything. If the patient is already severely hypocalcemic, then even our inotropes may not function properly. So those are things to consider. Now, whenever we have this hypocalcemia, just because we have hypocalcemia does not mean we have to treat, because most patients may have some degree of hypocalcemia. But if the patient is symptomatic, if there are ECG changes or very severe hypocalcemia, then we have to go ahead with treatment. And the modality of treatment that we use is this calcium gluconate. There are various protocols available, so you can follow whichever protocol your unit follows. So this is just an example of a protocol that has been given to treat hypocalcemia. Then we can talk about magnesium hemostasis. So magnesium is the fourth commonest cation that we see. And it's again has an essential role to play. From a cardiac point of view, this ECG change of Toza-Dupont. So Toza-Dupont can happen with hypomagnesemia. Hypomagnesemia and hypokalemia, they both have many features in common, and very often they are both associated. Usually hypomagnesemia itself alone does not cause problem, but it always, whenever we have this association with hypokalemia, we have to be worried about it. So again, it can cause a list of symptoms and signs. Again, uh, quite vague. So when we have this Tozzard, whenever we are faced with a patient who is having this Tozzard response, then the treatment is usually we are going to load the patient with magnesium. If this is due to secondary, so it may be due to other causes like ischemia and things, but if we are suspecting hypomagnesemia, then we are going to treat the patient with IV magnesium. Once we have loaded the patient with magnesium, we can go ahead with a continuous infusion to maintain the magnesium levels. Whenever we are giving magnesium, it's always important to keep an eye on the reflexes of the patient, because hypermagnesemia can lead to another set of problems like respiratory depression, cardiac abnormalities, cardiac arrhythmias, and things. So therefore, we do not want the patient to become hypermagnesiemic either. So for that, clinically, it's difficult to do magnesium levels for patients very regularly. But clinically, we can look at how the knee reflex is responding. So if the knee reflexes are starting to get depressed, then always suspect the patient is getting too much of magnesium. We may have to slow down the rate and then recheck the electrolyte levels. So in our labs, it's not that easy to get magnesium done. Very often it's done only once a week or something. So that's right. So that is for the main electrolyte abnormalities. Okay, so hypermagnesemia, as I said, it can occur usually in the context of administering magnesium. So there may be conditions like eclampsia for which we administer magnesium, even though the magnesium levels are normal. So for whenever the commonest reason is due to this exogenous administration of magnesium. So whenever the magnesium levels go up, it can lead to various issues like heart blocks, bradycardia, and things. And the way to monitor is to look at the tendon reflexes if you cannot check the electrolyte levels. If the patient is having severe hypermagnesemia, then we want to give IV calcium in the same way that we treat for hyperkalemia. We are going to give this hypermagnesemia to stabilize the cardiac myocardium, and then we are going to do dialysis or diuresis to remove the magnesium from the body. Okay, so that is all I wanted to talk about regarding this topic. So as I said, this is a topic that has been following us from first year medical students. It is something which in the clinical setting, it's sometimes very difficult. Is the patient fluid overloaded? Is there adequate volume? What are the electrolytes? Is what I'm seeing in the report, is it really reflecting what is happening in the patient's body? So there are many challenges in managing these patients. But I hope these pointers will will refresh your memory of these things and help in some way. So thank you very much for listening. Okay, I think there's a question here. Is calcium gluconate only indicated in severe hyperkalemia with ECG changes? Right. So that's a good question. So very often in clinical practice, we see whenever there is hyperkalemia, blindly for any high potassium, calcium gluconate. Then after that, only anything else. And then everybody forgets about the calcium gluconate as well. Now, calcium gluconate is given to stabilize the cardiac membrane temporarily to keep the patient alive until you can do something else to bring down the potassium. this calcium gluconate is not a treatment for potassium. Even if whatever calcium gluconate we give, if we check the serum potassium, it's going to be the same. It's not going to affect the potassium level. It's only going to keep the patient alive until we do other definitive measures. So we see blindly anyone hyperkalemia, we just give calcium gluconate. No one knows why. But yes, calcium gluconate is indicated only if there is ECG changes. Because if you have ECG changes only, that tells you, okay, now the patient is going. You see that all ECG changes don't suddenly happen. They just don't suddenly become going to sine wave. It's a pattern. Initially, first the T waves will go up. You have these tented T waves. Then the QRS starts broadening. Then the sine wave happens. So if we do not have any ECG changes, then there is no indication to give calcium gluconate. And if you think that you have to give calcium gluconate, it's important to keep the patient on a cardiac monitor and repeat the calcium gluconate if needed. That's another step that does not happen. Patients have severe ECG changes. People give calcium gluconate once and then forget about it. Half an hour, 1 hour later, you hear patient has arrested. Did you repeat the calcium gluconate? No. No one thought about it. So remember, you have to keep the patient. If you think that the patient needs calcium gluconate, then the patient needs to be on the cardiac monitor, and you have to keep an eye on what's happening on the ECG monitor. If changes are again starting to develop, then we have to repeat the calcium gluconate. Okay, there's another question in this chat. In a patient with heart failure and hyponatremia, how do we approach the management? Right. So again, as we said, this sodium abnormalities, hyponatremia, are usually due to a problem of water. So if you have heart failure and hyponatremia, then that means the patient is actually having too much of free water in the body. So the other thing that we see hyponatremia and heart failure is when we give Lasix or diuretics. So diuretics, they will remove the sodium from the body, and that also can lead to hyponatremia. So the management here is going to be, number one, is the patient symptomatic or not? If the patient is asymptomatic with a mild degree of hyponatremia, that can be accepted. We don't have to worry too much. But if the patient is hyponatremic and symptomatic, then again, yes, 3% hypertonic saline is going to be given. You have to administer it. We have to bring up the sodium level. If the patient is symptomatic, remember that. If the patient is symptomatic with hyponatremia, not just, we don't have to treat the report. If we see hyponatremia patient does not have any symptoms, then we can consider fluid restriction. That's free water restriction. Like that will improve the heart failure as well. So heart failure also, we go for fluid restriction to keep the lungs dry. So fluid restriction you can consider, but if the patient is symptomatic, then yes, despite the heart failure, you might want to give 3% hypertonic saline. Okay, another question, when correcting potassium, how often should potassium be checked? Okay. Now, that depends on the cause of this potassium. So I think you must mention, think about hyperkalemia. So when you talk about hyperkalemia, now the causes. Now, if the patient is having, say, something like a CKD, where there is reduced excretion of potassium from the body, in that case, if we give the potassium, then we can recheck after doing the correction. We can recheck the potassium maybe in 4 to 6 hours, and then we can do the necessary management. But there are other conditions, like say yellow oleander poison. Now, yellow oleander poisoning, when we in our setup here we have cerebrum manga poisoning. So both of these are cardiac glycosides, where they are going to inhibit or cause severe depression of the sodium potassium ATPase pump, where it's like you are having a leaking bucket. The potassium is continuously leaking out of the cells. So despite whatever we do, even when we give dextrose and insulin and try to send the potassium into the cells, we are sending the potassium in one side, all the potassium is leaking out of the cells on the other side because the sodium potassium ATPase pump is dysfunctional. So there you want to check the potassium more frequently. So we do it even 1 hour in some patients, in severe hyperkalemic patients, but at least 2 hours, we want to check the potassium levels in those patients. So anyhow, it's not you do potassium today and do it in the next, whenever you are correcting this potassium, because it's a life-threatening electrolyte abnormality, always we have to go at least 4 to 6 hours. It's not you do it today and then send the potassium next day morning. So we have to do it at least 4 to 6 hours.